Hello again, everybody, and welcome to case study number 11. This will be confusion in an alcoholic. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description or on the I button in the upper right-hand corner. I really appreciate all the contributions I can get to help offset the cost of these videos. I also appreciate your understanding in the fact that I am losing my voice, so if I sound a little wonky, that's why. All right, we got a 52-year-old white man coming into the ED with his daughter who says that he's been confused. 4 days ago, he underwent endoscopy and was found to have a bleeding duodenal ulcer which responded to omeprazole. He appeared to be recovering and was discharged after 2 days, but has since been progressively confused. He responds to his name, but is unable to reliably respond to other questions and is unaware of where he is. He's got a past medical history of cirrhosis and chronic alcohol abuse and has had one previous admission for acute pancreatitis. He works as an electrician and is single and not sexually active. On previous admission, he admits to drinking 6 to 10 alcoholic beverages per night. He doesn't smoke or do recreational drugs. His meds include omeprazole, clonazepam, and a multivitamin, and his vitals are normal. So what are we going to do for the physical exam? So our physical exam on this patient, we can actually do quite a bit more than we would ordinarily do in the ED, and we kind of have to because this is a patient who we don't exactly know what's going on other than that he's confused. So a lot of this stuff you can do just by looking at the guy. So it's not going to take you a lot of time. So he's gaunt appearing, he's got jaundice, he's got stigmata of liver failure, that would be the pulmonary erythema, spider angioma, and so forth. He's got icterus. Everything else, though, is pretty normal, with the exception of the fact that he's got a little bit of hypersplenia, and his neurologic exam is quite abnormal. So he's got asterixis, he's got hyperreflexia, and he's quite obviously altered. All right, so what do we want to do? Keep in mind that the number one cause of altered mental status overall is hypoglycemia. It's a very, 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 very common cause. I don't know if it's number one overall, but I should say it is the number one reversible cause of altered mental status, and it's very easy to treat. It's something you should rule out, and you can rule it out very quickly. You can get a finger stick blood glucose in seconds, so do it. Always, always do it. Even if you don't suspect it, even if you have something else that you think is more likely, just get your finger stick blood glucose. It's fast, it's easy, and you can rule out a very serious and reversible cause of altered mental status. So hypoglycemia is up there. We've got a couple different encephalopathies that we'll go into that are common with alcoholic patients. He may be withdrawing from alcohol. That can cause altered mental status. We know he's an alcoholic. Maybe he hasn't had access. Uremia is a possibility. Stroke is always a possibility in an older person who has altered mental status. Meningoencephalitis, an infectious cause. And then drug intoxication. So we know he abuses alcohol. It's possible he abuses something else. So what are we going to do for this differential diagnosis? We're going to get that finger stick blood glucose. We're going to get ABGs. You should always get ABGs in an altered patient. We're going to get routine labs as CBC and BMP. Because this guy's got liver failure, we're going to get LFT, blood ammonia, and LDH. And then we're going to get a blood alcohol level because there's the possibility that he's acutely withdrawing. And then we're going to get a urine drug screen. And what do we find? I highlighted all the stuff here in red that's abnormal. So we find that he's mildly anemic, probably not the cause of his altered mental status, but he's got a normocytic anemia. Okay, we also see that his renal function is normal. We see that his LFTs are all out of whack. The AST is higher than the ALT, so we know that he's got alcoholic liver disease. His blood ammonia is high, so we know he's got hyperammonemia. And his BAC is elevated. Well, he's got alcohol in his blood, so he's probably not withdrawing. And his urine drug screen shows benzodiazepines, which is not a surprise given that he's prescribed Klonopin. So putting all this together, we have a diagnosis of hepatic encephalopathy here. And you probably suspected that given that he has asterixis, which is common and is very stereotypical, but you do see it quite a bit. So the immediate treatment for hepatic encephalopathy is to ensure that he's got an adequate airway. That goes for anyone who's altered and, just out of it. And then the treatment is lactulose. So lactulose acidifies the intestine, and what it does is it takes NH3 or ammonia and converts it to NH4 plus, which is ammonium, and that is not as easily absorbed through the intestine, and so you'll have less nitrogen being absorbed into the bloodstream. The second line would be to add rifaximin to the regimen, and rifaximin is an antibiotic that kills off bacteria in the bowel, and that's a good thing in this case because bacteria make nitrogenous waste products, and so that will reduce the amount of nitrogen that's absorbed even further. And so really the cause of hepatic encephalopathy, as you can probably gather, is ammonia in the blood. We want to admit the guy to ICU. And so that's good to know, but what you really need to know are your ICU orders. So he's going to be on pulse oximetry, blood pressure monitoring, continuous cardiac monitoring, and then you want to know his I's and O's. And so we'll insert Foley, which we're going to need to do anyway since he's confused. We don't want him getting up to pee, and check I's and O's. As far as other orders, this one's big. So he's going to be on maintenance fluids, but we want him on maintenance fluids with thiamine. Anytime you got a patient who may be an alcoholic, certainly if they are an alcoholic, you always give thiamine with their fluids because you don't want to precipitate further neurologic decline. We want him on a low protein diet. Remember, protein is really our source of nitrogen in our diet. We cancel any precipitating medications. In this case, that's going to include the benzodiazepines, as Klonopin. We'll get a head CT for completion's sake. We can be fairly certain that this guy's not having a stroke, but you want to exclude it anyway. It's not going to be in your emergent or in your immediate orders, though. And then we'll consult gastroenterology because he's got liver failure. So hepatic encephalopathy is a reversible progressive decrease in the neurologic status, secondary to liver disease. The pathophysiology is poorly understood, but it's likely related to hyperammonemia. It is a diagnosis of exclusion, but typically you will see a predisposing cause present. So most commonly, the predisposing cause is a GI bleed, but it can also be due to infections, to certain drugs like sedatives, opioids, and diuretics. That includes benzodiazepines as far as sedatives. Hypovolemia, excess protein intake, electrolyte derangements, and status post portocaval shunt. Remember that a portocaval shunt bypasses the liver, and so by doing so, you reduce the amount of detoxification, and so you can increase the amount of ammonia in the blood. The presenting symptoms, obviously altered mental status, but look for neurologic abnormalities, including tremor, asterixis. That's that characteristic flapping of the hands. If you hold their wrist, you'll see their hands kind of flap back and forth. Hyperreflexia, clonus, and fetor hepaticus. That's not a neurologic sign, but it's a characteristic musty odor to the breath that you see in patients with liver disease. The labs, obviously hyperammonemia, it's a sine qua non, so if they don't have hyperammonemia, they don't have hepatic encephalopathy. Then also elevated transaminases, fairly non-specific though. So beware of precipitating hepatic encephalopathy in a patient who's admitted for alcohol withdrawal, because remember, when you've got a patient who is withdrawing from alcohol, they likely, possibly have some liver disease, but then what you're doing is you're giving them benzodiazepines to keep them from going into DTs. And remember that benzodiazepines can be a triggering factor for hepatic encephalopathy, so be very careful. Common differentials, we talked about hypoglycemia. Wernicke encephalopathy does show up in alcoholics, but the neurologic signs tend to be oculomotor dysfunction as opposed to the tremor and asterixis that you see more in HE. Delirium tremens tends to be agitation and seizure and less those more focal neurologic signs. Also look for a patient who's who's unable to access alcohol. So perhaps a patient who was admitted for to have his appendix taken out and has a history of alcohol abuse, but was not put on benzodiazepines. Uremia, look for renal disturbances in your labs. Stroke, it's hard to rule out. These patients tend to be more focal. Their labs are more likely to be normal. Older patient, you're going to get that head CT though. Meningoencephalitis, remember, stiff neck, fever, headache. is characteristic of meningitis. Add on confusion to that, and you got meningoencephalitis. Drug intoxication will rule out with urine drug screen. So to recap, confusion or altered mental status in an alcoholic should warrant suspicion for hepatic encephalopathy, Wernicke encephalopathy, or DTs, and you should always consider hypoglycemia. Remember that hepatic encephalopathy typically has a precipitating cause in a patient with history of liver failure, and that GI bleed is the number one precipitating cause. Wernicke encephalopathy has neurologic signs, but it tends to be oculomotor dysfunction, and DTs tends to be agitation and seizure in a patient who's unable to access alcohol, like in a hospital admission. Remember that elevated ammonia is a sine qua non, so if you have a patient where you suspect hepatic encephalopathy, make sure that you order that ammonia level. And the treatment is to ensure adequate airway, stop offending medications. Lactulose is first line. Lactulose plus rifaximin is second line. And then we want to admit these patients to ICU. Remember your ICU admission orders when you're taking CCS.